Thank you for inviting me. This is a great pleasure. I have the honor of talking about targeting triple-negative breast cancer for this series. And I think that to start off, one of the most important things to take a step back and say, why do we care about triple-negative breast cancer? And remembering that triple-negative breast cancer is defined as being negative for the clinical assays for the estrogen receptor, the progesterone receptor, and HER2. Now this makes up a minority of breast cancers, as you see from the pie chart, only about 15% or so. But because of the poor prognosis of this particular subtype, they make up a disproportionate number of metastatic cases and breast cancer deaths. And I think one of the highlights that is important also is the implications for treatment that I think other speakers have highlighted, but I'd like to sort of bring home to us. Remembering that triple-negative, like any other subtype of breast cancer, generally presents as early breast cancer. And if you have a classic case, as one shown here, of a stage 2 breast cancer with a baseline risk of recurrence of approximately 60% based on her tumor size and nodal status. If you have a hormone receptor positive breast cancer patient that's high risk, you add endocrine therapy to chemotherapy, and we all know that the residual risk of relapse is well under 25% for those patients. For those that are HER2 positive, we add anti-HER2 therapy, and again, you have a substantial improvement in outcome because of the addition of a targeted therapy to chemotherapy. On the other hand, with triple negative, we're reliant entirely on chemotherapy, and while our chemotherapy has certainly advanced over the years, having just that to rely on, our residual risk remains just under 50%, so it's substantially higher, and this is a real challenge for us. So Dr. Peru has already discussed the intrinsic breast cancer subtypes, and I think taking that from a clinical standpoint, just remember that these subtypes were identified in order to look at biology. They weren't identified in order to prognosticate or identify response to therapy or any of these other clinical parameters. It turns out that they actually do predict many of these things, but they are characterized by hormone receptor related gene expression, HER2 related gene expression. These are things that are clinically apparent, and the triple negative group are really those that are low expression of genes related to hormone receptor expression and HER2 receptor expression, and those are those that come up negative on clinical assays. This is not just one molecular subtype, however. The major components within the triple negative group on molecular assays are largely the basal-like molecular subtype. That's the majority of them. And then there's a very interesting subtype called the Claudin-Low that Dr. Peru mentioned that's been recently identified. So if you look at basal-like breast cancer from the standpoint of these gene expression arrays, as mentioned, they're low for the ER-related cluster, and I say that deliberately because ER itself may be positive sometimes, but generally the genes that relate to this expression pathway are low. Similarly for HER2-related genes, high expression of a unique cluster of genes called a basal cluster, which includes basal cytokeratins and EGFR, which we'll talk about later. They're typically very highly proliferative, often p53 mutant, and have evidence of genomic instability as one of their hallmarks, which may also be therapeutically relevant. The Claudin-Low subtype, we really don't have a lot of information yet. This is a very exciting area of research. They're a minority of tumors, only about 5% or so, again triple negative, with these interesting stem cell features that make them particularly intriguing. And as noted, some recent data sets suggest that they become enriched in post-treatment samples across a variety of treatments. Prognostically, these intrinsic subtypes, again, although they weren't designed in order to prognosticate, they actually are quite prognostic. And you see on the top, the best prognosis, luminal A subtype. The basal-like and the Claudin-Lows, which make up the triple negative, are outlined in the yellow and the red, and you see they have a significantly poorer outcome. So when we talk about triple negative, I think what's becoming clear is the triple negative phenotype on clinical assays enriches for this basal-like in particular subtype molecularly, but there is discordance between these two, and in particular you have triple negative breast cancers that are not basal-like on gene expression array, and that makes about 25% of them. On the other hand, you have basal-like breast cancers that aren't triple negative that are also about 25%. So whenever we're looking at clinical trials where you're trying to look at the basal-like biology and using the triple negative phenotype in order to get there, You're going to enrich, but you also have to acknowledge significant misclassification. So the Carolina breast cancer study that Dr. Peru mentioned gave us a lot of information about the clinical characteristics of these subtypes. And if you see here the red outlined basal-like subtype, he already noted the very interesting interaction with race and age, where young women and African American women are far more likely to develop the basal-like subtype. Other interesting features are that even though there's prognostic implications of these subtypes, they don't seem to do it by being necessarily much higher stage of presentation. As you see, that's not a significant difference, nor being more likely to be nodally involved. These are almost all invasive ductal carcinomas. They're almost all grade 3, and as noted, they often have P53 mutations. Behaviorally, there's some distinct characteristics across the subtypes. Triple negative in particular tends to have an early, a higher risk of early relapse, as shown here. This is a very nice analysis from the British Columbia Registry. You see here in the dark line the peaking of the relapse early, and then over time the risk of relapse falls off. And as has been noted in several data sets, the risk of relapse of a triple negative breast cancer after about 5, 6, 7 years actually is less than a hormone receptor positive breast cancer. And I think that kind of long-term impact and switching over of risk is something that has been relatively under-recognized until recently. In addition to the higher risk of early relapse, the sites of involvement of the different subtypes seem to be different. And what's shown on the bottom is a review from the MD Anderson database, and you see TNBC for triple negative breast cancer has a very high risk of visceral involvement upon relapse and a relatively low risk of bone involvement compared to, for example, the more common ER positive subtypes. And a couple of data sets have shown an elevated risk of having CNS involvement at some point during the disease. So what about our treatment choices? Right now we know that chemotherapy works and that advances in chemotherapy have particularly benefited this group. There's also very clear suggestion that anti-angiogenic drugs work in triple negative breast cancer, frankly, to the same extent that they probably work in all breast cancer subtypes. We don't have an effective selection strategy for this. Hypothesized approaches in triple negative are the idea of targeting chemotherapy, growth factor pathway approaches, and BRCA1 driven ideas that I'll talk about in a second. So what about chemosensitivity, conventional agents? The reality is that our conventional agents actually do work in triple negative breast cancer. And many patients come to me thinking that these are resistant tumors, and in fact that simply isn't true. And what's shown here are two data sets from the MD Anderson and from my own institution, UNC, very different, totally independent data sets, both using an anthracycline taxane-based approach in the neoadjuvant setting and demonstrating that the pathologic complete response rate to anthracycline taxane-based chemotherapy is quite high in basal-like or triple-negative breast cancer. So they do respond to standard chemotherapy, and in fact conventional regimens remain the standard of care for this subtype, particularly in the adjuvant setting. In addition, the implications prognostically of pathologic complete response are still true in this subtype as they are in all the subtypes. And what's shown here is a data set looking at pathologic complete response versus residual disease and outcome. And you see the blue dotted line is pathologic complete response to neoadjuvant chemotherapy in the triple negative subtype. And you see they have an excellent outcome. The difference in prognosis seems to derive from the fact that those tumors that fail to achieve a pathologic complete response have a higher risk of relapse than the non-triple negative subtypes, in part doubtless because the other subtypes, particularly the luminal ones, are receiving adjuvant endocrine therapy. So I mentioned anti-angiogenic approaches, and of course we all know that there are a lot of anti-angiogenic treatments that are either developed or in development, many ways to approach this. I'm going to focus on bevacizumab because that's the one, of course, that's had the most data in breast cancer. And what's shown here is a summary of ECOG 2100, the randomized phase 3 trial of bevacizumab added to weekly paclitaxel in first-line therapy for breast cancer. This was a relatively unselected group of patients, except that they had very few HER2 positives in there, so it's largely a HER2 negative data set. And as shown here, the addition of bevacizumab to weekly paclitaxel substantially improved progression-free survival. What the question is, of course, this was a relatively unselected group with a very expensive drug, and which patients got the benefit. You know, modern oncology is all about selection strategies and trying to match the patient to the treatment. What can we say about bevacizumab and anti-angiogenic strategies? At this point, using the clinical subsets they had available, they really saw that everyone seemed to benefit approximately equally, and what I have outlined in red is the ER and PR negative subset within ECOG 2100, demonstrating that that data set, that subset, which were triple negative because very few HER2 positives were in the study, benefited as much, if not a little more, than the average. This has been also demonstrated in some subset analyses of tyrosine kinase inhibitor approaches, including VEGFR. So what about the BRCA1 connection? You know, other people have noted, and this has been long recognized, that when women who carry germline mutations in BRCA1 develop breast cancer, most of the time those breast cancers are in fact the basal-like molecular subtype. But the truth is that while most BRCA1 carriers, when they get breast cancer, get basal-like, most basal-like breast cancers are arising in women who do not have an inherited problem with BRCA1. There's a supposition and an assumption based on some very good biologic data and preclinical data that there's something wrong with the BRCA1 pathway, but exactly what that is and how these things are connected has not yet been proven. Because there are some very clear connections between the two of them, there's actually been a term coined for this called Brca Nests, which are the characteristics that are shared between tumors arising in BRCA1 mutation carriers and sporadic tumors. And these are shown here. They include a variety of pathologic features, as well as things like a high p53 mutation rate, the basal phenotype, EGFR expression, and some very interesting related things like X chromosome inactivation pattern. And the final one, which I think is very relevant therapeutically, is sensitivity to DNA damage, and DNA damaging agents is a hallmark across these groups. So why would it matter if BRCA1 and sporadic basal-like breast cancers are similar? Well, the reason there's so much attention being paid to this is because of BRCA1's very important role in mediating DNA damage response, which has implications for targeted agents, the Parp inhibitors that we're going to be talking about, and also for certain chemotherapeutics. So what I have here is sort of a DNA damage repair summary, and in circles I want to notice that certain DNA damaging agents, particularly ionizing radiation and double-strand DNA damaging agents like platinating agents, in fact work, they cause their effect through double-strand breaks, which the repair of those breaks is dependent on a form of a pathway called homologous recombination. Homologous recombination is a BRCA1 dependent pathway. So if you lose BRCA1, you will impair homologous recombination. And why would that have an effect in terms of the chemotherapy? Well, this is highlighted in this slide where you see that on the left, DNA damaging agents. If you cause this particular form of DNA damage, BRCA1 is responsible for cell cycle arrest. The induction of a DNA damage checkpoint gives the cell a chance to repair itself, which would confer resistance to these agents because the cell would be able to repair the damage that the drug had caused. On the right, you see what happens if you lose BRCA1. Of course, you don't have a DNA damage checkpoint. The cell does not have an opportunity to repair itself, and it's killed by the drugs. Therefore, these kinds of drugs should be particularly sensitive in these cells. Now, this, of course, is theory, not fact. Do we have any clinical data to support it? We have some, but not very much. And I'm going to highlight some of the issues as you try to move these preclinical ideas to the clinic. On the top is a very interesting but retrospective analysis of neoadjuvant data set of BRCA1 of women who have BRCA1 germline mutations, 102 of them, so it's a substantial data set, treated with a variety of neoadjuvant chemotherapy agents, including a prospective trial of a few patients of cisplatin only. And what you see here is a really quite stunning pathologic complete response rate of 83% in the cisplatin only group compared to no more than 22% for any of the other regimens. Now, this is a retrospective study and it has certain baseline confounding issues, so this can be considered level 4 evidence, but it's very intriguing of a particular sensitivity to cisplatin in BRCA1 mutation carriers. On the bottom is a triple negative data set, very similar treatment, prospective trial in 28 patients with cisplatin only, showing a pathologic complete response rate of only 22% in this group. Now, 2 of these were BRCA1 mutation carriers. They both had PCR rates, so there's really a substantially lower rate of PCR in the triple negative group that was not BRCA1. So that calls into question our assumption of particular sensitivity that are shared between these 2 groups. So in this sense, I think the clinical jury is still out. What about Parp inhibitors? So many people are using the term synthetic lethality, which we've borrowed from our yeast genetics colleagues. The idea of synthetic lethality is that you can have cell death by dual targeting of pathways that themselves alone are not lethal. And that's illustrated here. If you see on the far left-hand side in a normal cell that receives some sort of DNA damage, they have several opportunities to repair that damage, homologous recombination, or, for example, base excision repair, which is highlighted because it's a PARP-dependent function. It can repair either of these ways, although homologous recombination is preferred and remains viable. If you lose BRCA1, you've lost the preferred way of repairing your DNA damage, the homologous recombination, but you still have the other, and you're again viable. Conversely, if you lose BER, you still have homologous recombination and the cell is fine, but if you lose both, the cell really loses its primary ways of repairing itself and it dies. So what about clinical data supporting this particular approach? Well, so what's shown here is a phase 2 study of olaparib, so an oral PARP inhibitor in BRCA1 or 2 mutation carriers. And it was given at 2 different doses. I'd like to focus on the 400 milligram twice daily dose because that's the standard one moving forward. Primary endpoint was response. And you see here that most of these were BRCA1 mutation carriers and half were triple negative. Really, in a pretreated group with a single agent PARP inhibitor, you see quite a remarkable result of 41% response and even some response in the much lower dose. Now, there was some toxicity in this trial. Fatigue was quite prominent, as were gastrointestinal effects, and about 30% of the patients had to either reduce doses or delay their doses due to toxicity, and that should be kept in mind. The other main one that's been studied, PARP inhibitor, is the IV one, BSI 201, in a triple negative cohort. This is a very interesting randomized phase 2 study that's been presented. Patients who were relatively untreated received gemcitabine with carboplatin alone, or the same with the IV PARP inhibitor BSI 201. As seen here, the response rate was really actually surprisingly low in the chemo-only arm, only 16%, but was really substantially improved to 48% with the addition of the PARP inhibitor. And unlike the other studies, this one had essentially no differences in either hematologic or non-hematologic toxicities. There's really no difference with the addition of the drug. Very well tolerated. And with a profound impact. And shown here, the progression-free survival went from just over 3 months to just under 7 months. And even more impressive in a phase 2 study, there was a survival advantage, as is shown here. So I'd like to close with sort of a cautionary tale about targeted therapy in triple negative breast cancer. You know, the EGFR is mentioned as part of the basal cluster. This particular target has been discussed, on a preclinical basis for many years. It's been shown that EGFR is present and expressed on tissue microarrays, that the cell lines representing basal-like breast cancer are EGFR dependent for growth and proliferation. So this made a very sensible target. It's being studied, but there are a couple of studies with data that are already out. One on the left, TBCRC 001. Cetuximab, which is an anti-EGFR monoclonal antibody added to carboplatin in pretreated triple negative, showed a response rate that was, 17%, which is which is considered modest, is better than expected, but not a home run. On the right, similarly, the addition of cetuximab to carboplatin and irinotecan in a subset of a U.S. oncology trial increased the response rate from 30 to 49%, but did not improve progression-free survival. And there are some other studies that will be providing additional data, but we get a lot of information from the wonderful patients who allowed us to perform serial biopsies in TBCRC 001 of their target tissue before and after starting treatment. What I show here is one tumor. So on the left is a cartoon of the expression profile from one woman's tumor pre-treatment. And you see on the top, EGFR, red is on and green is off. So the EGFR target is turned on. There's a group of genes on the bottom that represent activation of the EGFR pathway, and those bubbles representing those genes are more red than green, so that means that the pathway is activated. And 1 week later, you see that the pathway is completely inactivated by the drug. And this patient, similar to what was happening on a molecular level, she was a long-term clinical responder to this drug. Would that was the way all of the patients responded, but it wasn't, and we learned a lot from this. So you see, this is another tumor, and this I call the one dumb tumor is still smarter than 10 smart oncologists slide. You see on the left, again, the representative cartoon from one woman's tumor pre-therapy. You see the EGFR is turned on, the pathway is activated. 1 week later, nothing has happened. So even though she had the target and it looked like it should work, the drug did not work. And that actually was true of the majority of these tumors. Only 25% of the tumors actually had activation of the pathway that was then deactivated by the drug. And in the other 75%, the drug was ineffective, probably because there were alternate mechanisms that we don't know enough about yet, keeping the pathway turned on so the drug alone wouldn't work. And I think that's going to be true of many of our targeted therapies as we move forward, and is a real challenge. I think that also is the opportunity for us to take advantage of neoadjuvant therapy, because we can collect correlative science data and tissue-based data at the same time as clinical data is really our way forward. So to close, we all know that in developed countries there's been a really remarkable improvement in mortality from breast cancer. But in truth, almost all of that benefit has occurred in the ER positive and HER2 positive subsets, and triple negative is our biggest challenge moving forward. Thank you very much.